So the first speaker was Dr. Samir Parikh from Ohio State University. He works very closely with Brad Robin on lupus nephritis, and I thought I would start with his talk. So the first question is, how are we doing with lupus nephritis? This is a graph looking at the probability of end-stage kidney disease throughout the decades, the 5, 10, and 15-year survival throughout time. And what we can see is once corticosteroids were started and cyclophosphamide was started, we saw that there was an improvement in avoiding end-stage kidney disease. However, lately, it really does not seem like we have made much progress. And in fact, around here is when the use of mycophenolate mofetil was started, and you could argue that perhaps outcomes are a little bit worse. So what could we do to improve these outcomes? Mycophenolate mofetil and cyclophosphamide. So these are the partial remissions, and these are the complete remissions at 6 months between, again, in the red, cyclophosphamide, and in the orange, mycophenolate mofetil. And what we can see is that at 6 months, the complete remission rate is terrible. It's less than 10%. What we would like to see, of course, is that this complete remission rate is much higher, because this is what's going to determine the chronicity of the disease. So we want to try to improve this complete remission rate. We want to improve induction therapy results. So again, just the point was, again, that our complete remission rate in lupus nephritis induction therapy is very poor. Now, why is that? One of the reasons is that basically we don't exactly understand the pathophysiology of lupus nephritis. There are many, many factors involved. We have T cell activation, B cell activation, plasma cells, we have interferon alpha, and we have activation of complement. So many, many possible targets. And because every patient doesn't have the same things that are causing the problem, it's very difficult to use targeted therapy. Now, we're going to talk about 3 different studies that try to target different aspects of the immune system. We're going to talk about the use of a new anti-CD20 molecule, obinutuzumab. We're going to talk about calcineurin inhibitors and a new calcineurin inhibitor that use much the same as the therapy pioneered in China for multi-target therapy. It's voclosporin. And finally, we're going to use anti-BLyS therapy with belimumab, again, to target B cell activation. So we're going to start with obinutuzumab, a phase 2 trial for lupus nephritis. Now, we know that in the LUNAR trial, rituximab, the anti-CD20 antibody, really did not work very well. So one of the thoughts is, could we have a better anti-CD20 depleting antibody? So obinutuzumab is a humanized type 2 antibody. And what that means is that rituximab in B cells internalizes. It does not stay at the cell surface. With a type 2 antibody, obinutuzumab stays at the cell surface and then can act with natural killer cells, neutrophils, and macrophages to cause more immunosuppression. So as a result of this, there's increased antibody-dependent cytotoxicity, 100%. There's increased direct cell death. And as a result, there's more peripheral and lymphoid tissue B cell depletion. So in this trial, they used standard therapy with mycophenolate mofetil and steroids, and they either used obinutuzumab or placebo for class 3 or class 4 lupus nephritis, where the eGFR was greater than 30 mils per minute, looking at the complete response rate at week 52 and the overall response rate and some of the markers as well. Again, mycophenolate mofetil was used at a dose of 2 to 2.5 grams per day. Oral prednisone was started at 0.5 milligrams per kilogram, tapered to 7.5 milligrams by the 3rd month, and then completely held until week 52. So a very short oral corticosteroid dose. So what were the results using this new anti-CD20 antibody? So the complete response rate in the blue at week 52 and week 76 was higher than the standard of care therapy with mycophenolate mofetil and corticosteroids as far as the complete response rate and the combined complete and partial response rate. Again, we see week 52, we see week 76. So it appears again that this new anti-CD20 antibody performed perhaps better than rituximab. Here again is that complete response rate over time. Here where they gave the antibodies at time 0 and 2 weeks later, 1 gram, and at the 6 month and 2 weeks later. So 4 total doses. Okay, here was the standard of care therapy at week 76 for the complete response rate. Here was using the antibody, a higher response rate at week 76. Okay. One thing that the investigators looked at was, what did B cell depletion look like with the new obinutuzumab, and could we compare that with the standard rituximab? So this was, again, the LUNAR trial looking at rituximab and MMF. This was the new phase 2 trial looking at the percent of patients with CD19 positive cells less than 5. And what we can see is very quickly that the new anti-CD20 was much better at depleting B cells than rituximab in the LUNAR trial. So this may be one reason where this was a more effective therapy than rituximab might be in this phase 2 trial. When they looked at adverse effects, really the death rate, the serious adverse events, the serious infection rates really were very, very common between either the obinutuzumab and the standard of care without obinutuzumab. So it appeared to be very safe in these phase 2 trials. So this is something perhaps that we can look forward to, and we will come back to this as possible. What could we use in other glomerular diseases in the future? Okay. So another study, again, looked at multi-target therapy pioneered by Professor Liu, but it looked at a different type of calcineurin inhibitor, voclosporin, instead of tacrolimus or cyclosporin. Now, voclosporin is a modified calcineurin inhibitor. It binds calcineurin much greater than the traditional calcineurin inhibitors. It's thought to be 4 times more potent. It is also metabolized faster, so patients are not exposed to metabolites as much as with the traditional calcineurin inhibitors. The pharmacodynamics, the absorption, the effectiveness is thought to be much more uniform than the other calcineurin inhibitors. And in fact, you do not have to obtain levels of voclosporin. So what they did was they looked at either standard therapy with placebo mycophenolate mofetil and oral corticosteroids versus low-dose voclosporin plus mycophenolate plus the oral corticosteroids. Now, they used a very short course of oral steroids. They started at 0.4 milligrams per kilogram per day of prednisone, compared to Professor Liu's study where it was 0.6 milligrams per kilogram. And they were at 2.5 milligrams per day by month 4. So again, a very short course of oral corticosteroids. Again, the trial was for 52 weeks. So what did they find in this phase 3 study? So they found that, again, the complete response rate was much higher in the voclosporin group than the control group. Now, this was not as great a response in the Chinese population used by Professor Liu at 1 year. However, the difference at 1 year at week 52 remained at 18.3%. Remember, with Dr. Liu's study, there was an initial change, an initial difference, but through time, it tended to come closer and closer together. This was week 52. It remained different between the voclosporin and the traditional therapy group. Now, one thing with the phase 2 trial using voclosporin, which was not really understood, was that there was an increased death rate, actually, in the low-dose voclosporin group compared to placebo and the high-dose group. Now, many of these deaths, and there weren't that many deaths, but they were early in the trial, so the thought was perhaps they were really not related to the low-dose voclosporin. And again, the low dose had a higher death rate than the high dose in the earlier phase 2 trial. So this was a very important thing that they wanted to look at in the phase 3 trial. And what they saw was that, again, the adverse event rate between the voclosporin and placebo, similar. The adverse events leading to death, which again was higher in the phase 2, was similar between the two groups. And therefore they felt, well, at least in this phase 3 study, this appeared to be as safe or safer than, or as safe, I'm sorry, as the control group. So again, this is a way to use multi-target therapy. Perhaps it would be a way that through time, you continue to have the difference between the multi-target therapy and the standard of care. So could this be a better calcineurin inhibitor to use? Again, binds calcineurins more, 4 times more potent, and less metabolites. Okay. And finally, this was the New England Journal reporting the use of belimumab for lupus nephritis. So again, for B cells, what we say is B cell activating factor can bind to 3 receptors that increase B cell survival and maturation, plasma cell survival, and B cell survival and proliferation. Belimumab blocks these 3 receptors, leading to, again, less B cell activation, plasma cell activation, and perhaps improved outcomes for induction therapy. So the protocol was you could use either induction therapy, intravenous cyclophosphamide and azathioprine, or mycophenolate mofetil, combined with IV and oral corticosteroids. And then either placebo or belimumab was given. Now, belimumab was given very, very often. So initially, it was given at time 0, 2 weeks, and 4 weeks, and basically every month afterwards till week 104, belimumab was given intravenously. So a lot of belimumab was given during this trial. So what were some of the baseline characteristics? So what's interesting again is, not surprisingly, most are women, but half of this group was an Asian population. Here are the classes of lupus nephritis balanced between the 3 groups. The urine protein to creatinine ratio per 24 hours, somewhat over 3. Okay, the GFR was pretty well preserved, with only a small number having a GFR less than 60 mils per minute. So what were the results using belimumab? So this was the probability of both a complete and partial remission. Okay, so this was the standard of care therapy group. This was the belimumab group. The hazard ratio was 1.46, which was statistically significant. What about our complete remission rate? Okay, so again, remember we were thinking at week 24, at 6 months, really either using cyclophosphamide or mycophenolate, it was less than 10%. I'm sorry. And here we can see that compared to standard of care therapy, that belimumab was better. So again, the hazard ratio 1.58 over the 2 years between the two groups. This was a renal-related event or death, again, lower in the belimumab group compared to placebo. And if you look at these very carefully, what you saw was, here are the number of events for renal-related event or death. Most of the difference was because there was more proteinuria, impaired kidney function, or both between with the placebo group compared to belimumab. Okay. Here's the adverse events. What we can see is really pretty common or pretty equal between the two groups. So even though belimumab was given very, very often, in this trial, there did not seem to be more adverse effects using belimumab. Okay. So to sum up, lupus nephritis, we may have better CD20 B cell depletion antibodies. We may have better calcineurin inhibitors, and the addition of anti-BLyS therapy, anti-B cell activating factor therapy, may lead to an improvement in our results for induction therapy. Okay. So next, I'm going to turn to membranous nephropathy. Okay. So with membranous nephropathy, again, one of the hallmark changes, or one of the discoveries that's really been a landmark discovery, is the PLA2R discovery and the antibody titer. Now, traditionally, what we've been taught to do is to wait to look at proteinuria to see if proteinuria worsens over 3 to 6 months, the serum creatinine worsens, and only then to start immunosuppressive therapy with primary membranous nephropathy. So this was a paper by Dr. De Vries, where they thought that with PLA2R therapy, perhaps we should look closer at the immunologic response. And whenever you see an increased titer to start immunosuppression, whether there's high titer of PLA2R antibody, or if there's moderate to low titer, but again, if you continue to watch this monthly, okay, again, start immunosuppression if you see the titer is going up. Why not start therapy earlier when the titer is rising? Okay. So as far as therapy, the hallmark therapy, the gold standard therapy, is the Ponticelli regimen. And I'm not sure how many people have used the Ponticelli regimen in China and really throughout the world now. It's not that common. So again, to describe this, at months 1, 3, and 5, patients are given 1 gram of methylprednisolone for 3 days. For the rest of that month, they're given oral methylprednisolone or oral prednisone for the rest of that month. At months 2, 4, and 6, they are given oral cyclophosphamide, 2 to 2.5 milligrams per kilogram per day. And that 6-month course is the Ponticelli regimen. Now, when you look at the 10-year follow-up, the probability of complete and partial remission between the Ponticelli group and supportive care, so no other immunosuppression, we can see that there is a better response rate with the Ponticelli protocol. And remember, the therapy stops at 6 months, and what we see is continued through time. There are more and more complete and partial remissions. And because this has been shown to be a difference at 10 years, this is really thought to be the gold standard of therapy. Now, one of the issues was, can we use now rituximab for the use of primary membranous nephropathy? Can we use this for treatment? Now, in the initial discussions, which I was a part of, really the thought was, should we compare rituximab to the Ponticelli protocol? The problem with the investigators, what they thought was, not that many people use the Ponticelli protocol. You would not be able to get a comparator group. So it was decided that cyclosporin would be the comparator group in the MENTOR trial. So in the MENTOR trial, rituximab, 1 gram was given at day 1 and 15 versus cyclosporin, 3.5 to 5 milligrams per kilogram per day. And at 6 months, if you had less than the 25% reduction in proteinuria, you were considered a treatment failure. If you had a complete remission, therapy stopped. If you had a partial remission, you continued therapy. So again, if you had a partial remission, you again got 1 gram at month 6 and then 2 weeks later. If you had a partial remission with cyclosporin, you continued on 3.5 to 5 milligrams per kilogram per day. It turns out no one in the rituximab group had a complete remission, and only 1 person had a complete remission in cyclosporin. So the vast majority of people were retreated and kept treatment. At month 12, cyclosporin was just stopped altogether. Okay. So what were the results of the MENTOR trial? So this was at 24 months, looking at the complete and partial remission rate between cyclosporin and rituximab. And remember, the vast majority of patients got 4 1-gram doses of rituximab. So what we can see is at 6 months, there was a problem. Many people, or a certain percent, dropped out due to treatment failure or just an inability to get that complete and partial response. Now, 12 months, the difference between cyclosporin and rituximab, very, very similar. But in the protocol, at 12 months, cyclosporin had to be stopped. And what we can see is, again, that that there is really a drop-off, a relapse rate once cyclosporin was stopped. And I don't think that's very surprising to anyone here, that cyclosporin, if you're going to use it for membranous nephropathy, it has to be used for a long period of time with a gradual taper. Okay. So now one of the questions was, what if we compared the combination of a calcineurin inhibitor plus rituximab to the Ponticelli protocol? So here's the Ponticelli protocol, the 6 months alternating glucocorticoids and cyclophosphamide. And here was the Starman protocol. So it was the use of tacrolimus for 6 months, followed by a taper. And one of the thoughts behind this was, if you have a massive amount of proteinuria, you will actually lose rituximab in the urine. So if you could reduce the proteinuria and give just 1 dose of rituximab, perhaps you would get more efficacy with the combined therapy. And you would only, again, use 6 months to 9 months of tacrolimus, a very short course of tacrolimus. So what would happen in that situation? Now, I must say, the investigators felt that they were thinking you would get about an 85% complete and partial remission rate with this regimen versus a 60 to 70% complete and partial remission rate with the Ponticelli protocol. So what did they find? They actually found that the opposite occurred, that the corticosteroid cyclophosphamide complete and partial remission rate was greater than the tacrolimus rituximab rate. So this was about 85%, this was about 60%, okay? Now, remember, in the MENTOR trial, with just cyclosporin, the complete and partial remission rate was only 20%. So using the shorter course with 1 dose of rituximab, it was better than just the calcineurin inhibitor alone. Remember, in this group, they only had 1 dose of rituximab. In the MENTOR trial, they had 4 doses. So again, the response rate was about the same, 60% to about 60%. Okay. So here was looking at proteinuria and PLA2R titers. So in this light blue is PLA2R titers. And what we can see is with the Ponticelli regimen, they became negative after 3 months. In the tacrolimus rituximab group, you can see that it took longer. It took about 6 months for there to be an immunologic remission. So it took longer. Now, one thing with this trial that was not very well balanced was PLA2R titer. Okay. So what we can see is that in the Ponticelli regimen, the titer was about 60 on average, whereas with the tacrolimus rituximab group, it was about 112. So they had a higher titer on average than this group. However, again, the results were somewhat disappointing. So again, one of the thought processes are to really treat membranous nephropathy. Should we combine B-cell therapy, perhaps with rituximab, or the newer anti-CD20, could obinutuzumab, again, better at depletion, would that have acted better? And should we use this in a different way? Instead of waiting till the end at 6 months, could we use it in the very beginning, and perhaps at that end, would that have resulted in a better efficacy than perhaps the Ponticelli protocol? Not clear, but again, some things to learn and think about with this new trial that was just published for membranous nephropathy. Okay, and finally, I wanted to talk about pauciimmune glomerulonephritis, ANCA glomerulonephritis. Now, it turns out, although these incidence rates seem small, it is something that is seen in China. It seems to be more prevalent or in northern China, with this ethnicity having the greatest incidence. In China, it appears that MPO ANCA positivity is more than PR3 positivity. So what about induction therapy in the very, very severely ill as far as renal disease? So this was the MEPEC study that looked at serum creatinine levels greater than 500 micrograms per liter. And what they did was compared standard methylprednisolone versus the use of plasma exchange with oral steroids and oral cyclophosphamide in both groups. So this was back in 2007, short-term follow-up. And what we could see is that when you use plasma exchange, there were greater patients that were not on dialysis, that avoided dialysis, than with standard therapy. Now, if you looked at death rate, there was not much of a difference. But if you survived, you had a greater chance, if you had plasma exchange therapy, of being off dialysis. Now, unfortunately, when you looked at longer term results, 10-year follow-up, really as far as the hazard ratio for death or ESRD, it crossed the midline. Death crossed the midline. Really, there did not seem to be much of an advantage of plasma exchange. Now, then the next question is, well, you compared IV methylprednisolone to plasma exchange. What if you combine the two and compared it to IV methylprednisolone? Okay, so this was the PEXIVAS study that looked at people with severe ANCA-associated vasculitis, those with eGFRs less than 50 or diffuse pulmonary hemorrhage. And they were treated with either induction therapy, cyclophosphamide or rituximab with IV methylprednisolone. And they could be either treated with plasma exchange, 7 plasma exchange treatments over 14 days, or no plasma exchange. Now, one of the important principles I think that is really you're going to see with the upcoming KDIGO guidelines is the really push to reduce oral steroid doses. So a second part of the trial was to compare standard dose oral glucocorticoids with reduced dose oral glucocorticoids. Would they be equivalent as far as efficacy? And if they were, that would be very, very beneficial. So again, here's the PEXIVAS protocol. And again, if I just want you to say, this is the standard protocol, this is the reduced protocol, and you can see by week 2, here's standard oral prednisone dose, Here's the reduced dose. By week 2, you have cut this in half. So this was a much lower reduced oral corticosteroid dose. Okay. So again, looking at baseline characteristics, patients over 60, most were NPO ANCA between plasma exchange, no plasma exchange, reduced steroid, and standard steroid. What we can see is this was a group that had very severe renal disease. Almost 30% had a serum creatinine greater than 500 micromoles per liter or were on dialysis, and almost 20% were on dialysis. So a very severely affected group as far as renal disease. For pulmonary hemorrhage, about 19% had not severe pulmonary hemorrhage, whereas about a little less than 9% had severe pulmonary hemorrhage. Severe pulmonary hemorrhage was defined by a room air pulse oximetry less than 85%, or if they were on mechanical ventilation. So what were the results of this trial? So using plasma exchange or no plasma exchange, death or end-stage kidney disease, there was no difference between the two groups. Unfortunately, there was no benefit of using plasma exchange. But the good news was using that reduced versus standard dose glucocorticoids, there also was no difference between the two groups. So I would say this is a very positive result. Okay. If you looked at secondary outcomes, here's plasma exchange versus no plasma exchange, perhaps there's a little bit better hazard ratio. However, again, it crosses the midline from death of any cause or end-stage kidney disease. Again, serious infections, more with plasma exchange, but it was not statistically significant. Here's reduced dose versus standard dose glucocorticoid. Death from any cause, again, didn't cross the midline, but sort of it seemed to favor a little bit the reduced dose. End-stage kidney disease, I thought this would be higher with the reduced dose, but really no change, again, crossing the midline. So the one thing that I think is not quite answered from this trial is that if you looked at diffuse pulmonary hemorrhage, okay, the hazard ratio is lower for both severe disease and non-severe disease. Again, it crosses the midline. There were 95 versus 96 patients, so it was the largest trial to date. But again, if there were more, would there have been a difference if you had pulmonary hemorrhage? We're not quite sure. Okay. So what I wanted to do again was just end with that. Again, with lupus nephritis, perhaps we have new anti-CD20 therapy, new calcineurin inhibitors. Perhaps we'll be using anti-BLyS therapy. For membranous nephropathy, perhaps the new thought would be combining T-cell therapy with calcineurin inhibitors for a short course with B-cell therapy, perhaps rituximab more often than what was used in the Starman trial, or perhaps the obinutuzumab. And finally, for ANCA vasculitis, severe ANCA vasculitis, even in that state, perhaps reducing our oral glucocorticoid dose versus the standard. And again, with severe disease, it did not seem to make a difference. For plasma, for those with pulmonary hemorrhage, I'm not quite sure. I think we still have a question about that, but it does not seem to be very significantly improved using plasma exchange. So with that, I wanted to thank everyone for allowing me to speak today. I'm sorry for the technical issues, but again, it is really my honor to be able to speak to all of you today about some of these upcoming trials that perhaps we can share together and use. So thank you so much.